Good morning and welcome to the second day of ICPLP2021. As usual, please ask all your questions on Slido. You can find us under the number 635252 or using the QR code either in our conference locations or just directly beneath the stream. And now I have the pleasure to introduce our first speaker of the day, Kate Lancaster, physiotherapist at Queen's Mary's Hospital, and her workshop on graded motor imagery.
Good morning, everybody, and thank you very much for having me for the conference. I hope you've all had a really good night's sleep and you've all got your cups of coffee or tea to get you going. Right, let's get these screen shared. Okay, all right. So as said, my name is Kate Lancaster and I'm a physiotherapist specialising in amputee prosthetic rehabilitation at Queen Mary's Hospital in London. Just to start off, there's a funky little QR code in the corner. It's nothing too exciting. It's just basically a piece of paper with some numbers written down the side of it, which you don't really need to link onto, but I would really appreciate it if now, quickly, you could write down the numbers 1 down to 28 down one side of a piece of paper. Hopefully it'll all come clear later on through the presentation. This is a workshop, and to me a workshop is basically trying to be interactive. So I would very much welcome questions throughout the workshop, but I'll try and answer them at the end of each section, and hopefully that will come quite clear as we go through. All right. Okay, so I started working in amputee rehab back in 2009 with very little understanding or appreciation of chronic pain. In fact, I was pretty rubbish at treating any patients with chronic pain. Come into amputee rehab and was basically faced with a whole bunch of patients who were experiencing phantom pain, and I had even less knowledge of that. I was then really fortunate enough to go to a conference in November of 2009, which was hosted by BACPAR, which is the British Association of Chartered Physios in Amputee Rehab. And they had a couple of presenters from the Neuro Orthopaedic Institute presenting on explain pain. And it was the first time that anybody had truly explained something to me that made me go, oh, okay, that makes sense. I get it now. Well, kind of get it now. I need to know more about this. And felt that it would be really applicable to help with our patients with phantom pain. The following year, they happened to be doing a couple of courses, the 2-day course on explain pain, and then also the 2-day course on graded motor imagery. And it's been pretty much from that point that I've started using it for treating our patients with phantom pain. I was then also fortunate enough to go on the courses again, basically in 2015, and I found that really helpful just to refresh. And I'd first seen it in 2010, everything was so new, there was so much information, it was a lot to take on board. So 2015 was a really good refresher, and they'd actually introduced a couple of other things as well, which I've been using well. Okay, so this workshop is literally my experience of working with phantom limb pain patients. I am a clinician, I am not a researcher. So hopefully this is a way of basically forwarding on and hopefully some tips and tricks on how to use these techniques. Okay, so what is pain and why is it that I can feel my phantom? Basically, pain is a truly complex topic, and it has been and will be discussed pretty much at length throughout this conference. But our patients really don't understand why they can feel pain in something that's no longer there. It scares them. I think that was mentioned quite nicely yesterday as well. And therefore, education is a really big part in what we do to help reduce down this fear of their phantoms and of their pain, and why they're experiencing this. So we do education sessions once every 6 weeks, and one of those is around pain and phantoms, hence my little graphics. The explained pain model is all based around the biopsychosocial model, or Melzak's neuromatrix theory, which explains that your brain basically takes on information from absolutely everywhere. It basically then has to try to decide whether you are in danger or not, and then it has to decide which outputs to give, one of which can be pain. It can be extremely challenging for patients to rethink pain and shift their idea that pain is a measure of the state of their tissues into something that your brain is doing to try to protect you, and therefore that everything matters. When we first meet our patients, we try to reassure them that they're not going mad. I think a lot of people really do think that they have lost it a little bit, and that they can still feel their phantom, and that that's okay. As we've mentioned before, over 80% of our amputee patients can feel their phantoms, and certainly what I find when I ask, do our education sessions, that's definitely about right. And that around 90% of those that can feel their phantoms also experience pain. We give them an information leaflet about phantoms and pain, which they can then take away and read in their own time. And we try and basically include talking about phantoms throughout their time with us in rehab. There are differences between primary and established amputees. So just to explain to us, primary amputees are patients who have literally just had their amputation and are starting with us in prosthetic rehab. I think established is fairly easy to work out. And part of the education sessions is also trying to get them to understand how other things going on in your life and world events will also impact on their pain. Okay. So I use something called a pin box to help to explain this really complex topic. And nobody does this better than David Butler. So this is a little video taken from YouTube that he's done, which is much better than me trying to explain it. So bear with me and let's hope that this works.
It can be hard to explain brain function, neuroplasticity, and the changes that happen in the brain in pain. And it's not an easy thing to tell somebody that pain is made in the brain. It's all a bit abstract. You can't see brain function. It's in 3D. But explaining pain and explaining the role of the brain in pain is a critical part of the explain pain work. These nail boxes may help. We all had one of these in the 70s. They're still around, easy to find, and they may well be making a comeback. Normally, we know our hands well. There's a lot of territory in the brain representing, looking after each hand. We can move each finger independently. We know where our hands and fingers are in space. You know when each finger is being touched, and we can do remarkable things with our hands. We could write, sculpt, play musical instruments, and talk. Let's say that each of these nails represents 1 million cells in the brain. And these will be cells that have neural and immune functions, and they work very closely together. We know our hands in the brain because these cells here, representing each finger, at a particular time and place can be turned on, and these ones in between turned off. The science term is inhibition. We also know that it changes dramatically. For example, if you have 2 fingers held together with a bit of tape, they will join up in the brain. Essentially, they become sticky. But within a few hours, with normal movement, this will reverse. Talk about use it or lose it, there's a lot of that in the brain. In pain, things are a little bit different. We know things can change dramatically. Let's say that the person's index and middle finger is in trouble, maybe in pain, not being used, frightened to move. What can happen if the brain makes the conclusion that more protection is needed? It can call upon neighbouring cells, neighbouring immune and neural cells, brotherhoods, sisterhoods, cousinhoods, neighbourhoods of cells, and pull them in to the territory looking after the fingers. So we call this smudging, or the science term is it becomes disinhibited. This remarkable defence might be helpful in the short term, but not so much in the long term. In the long term, you might not be able to recognise the difference between two fingers. It might feel a little bit different, not yours, a bit bigger, a bit smaller, perhaps. And you may start to see changes in activities, particularly high-level activities like playing a musical instrument, writing, doing up a button. These plasticity changes, of course, are not just confined to the hand. This can happen anywhere in the body. This sounds bad, but it's happening all the time. It happens in all of us. It's a very useful defence. The aim should be to get to know the hand again, to love the hand again, to re-embody the hand again. In a science sense, to take away or inhibit these cells in the middle which have joined on and become sticky with the original fingers. There's three main ways in which you do this. Principally is education. If you can take away usually the fear that made the brain construct this defence, that would be number one. Secondly, graded exposure, graded activity, which could range from thinking about movement to actually moving. And thirdly, taking the hand out into different contexts, feeling different surfaces, feeling different places, exploring with the hand in space. So here we have a very simple addition to the media of teaching. And one of the really good things about it is someone can actually do it themselves and feel what is going on. It actually feels quite nice too. Have a go yourself.
Okay, so he is an incredible educator, and I use basically some stories with the pin box myself as part of our education talk. And patients really do seem to grasp it. I think it's really important that they understand why we generally experience pain. I know he's talking about clearly hands that still are there, but I think, I don't know, like I said, I'm not a scientist. In terms of the smudging effect, that if something is in pain, if the brain is thinking, oh my goodness, I can't feel my leg, what's going on with my leg, why can't I feel it? Then maybe it's fair enough to assume that it will have this smudging effect. I often say to patients, have you ever fallen asleep on your arm and your arm's gone dead in the middle of the night? Well, who's to say that maybe phantoms are in some respects something similar? The brain has thought, oh my goodness, you've fallen asleep on your leg, or you put it in a funny position, which means that you can't feel it anymore. I'm going to give you some pain to try and help you to move it and re-find your leg again and make sure it's okay. All right. So, slide. Okay. So that is basically us trying to explain a bit around pain. But like you said, what are we going to do about it? We need to do this graded treatment approach to try and re-normalize things. And this is where graded motor imagery comes in. So graded motor imagery was developed basically by two Australian musculoskeletal physiotherapists, one of which was David Butler, the other Lorimer Mosley. And they were curious from trying to treat chronic pain patients, what they had told them, frustrated with some treatment processes that were working and others that didn't, and wanting to know how to help these patients more. They'd tried the mirror therapy. Some had worked, some hadn't. And they knew that this fired off the motor cortex. They knew that imagery was essentially based off the Pavlov's dogs and mirror neurons. But again, sometimes these techniques, they failed. So what can be easier and fire off less neurons? They came across some research developed which reported delaying reaction. They came across research reporting delayed reaction times in left and right judgments with people who were in pain. So a combination of the growing understanding of underlying neurobiology of complex pain states and their experiences, they developed this treatment technique. So graded motor imagery is a graded treatment approach, basically to re-educate the brain to normalize the signals it receives, so as not to interpret them as pain when the body part is no longer in danger and therefore is pain-free. It is very much based on the fact that the brain is changeable and adaptable, and hopefully this links in quite nicely with what Tamar was trying to say yesterday. It's how we learn or unlearn tasks and bad habits. Aren't bad habits always so much harder to unlearn? If the brain couldn't change, then our patients or us, we would never be able to learn anything new. So I really put this across to the patients. They are changing all the time. While they're in their prosthetic rehab, they're learning how to manage with their prosthesis, how to manage in a wheelchair. But there are other more general things. It's how we learn new languages or a new skill like playing the piano. And we don't learn those by going to a class once a week. I know. Okay. So just from what David Butler's just been saying as well, is that with persistent pain, the brain develops this poorer view of the tissues, and that fear can make these worse. But as they say in Explain Pain, bioplasticity got you into this mess. So therefore, why can't bioplasticity get us back out of it? It's so important for the patients to understand this and grasp that the brain does change, because it gives them hope. I tell them, like I said, I'm changing their brain connections right now about their pain and phantoms, and that we have that ability to change our brain's view on the state of our tissues, or in our patient's case, on the state of their phantom, so that we can remind ourselves of what normal is, and that they are no longer in danger, and therefore it shouldn't be painful. So correcting the brain's view is essential in treating pain. Graded motor imagery consists of 3 different stages or components. These are left and right discrimination or judgments, motor imagery, and mirror therapy. It's hard work, okay? To make changes in the brain is difficult and requires lots and lots of practice to embed change. Therefore, it requires patience. And I have to say, not just purely from the patient point of view, but also from the clinician treating. It takes one step at a time to not exceed training load just because it feels good today. And I definitely have examples of that from patients that I've been treating who try and push the boundaries, and they come back to me and go, oh gosh, I shouldn't have done that. That definitely made me fizz more. It takes persistence. It takes a long time for graded motor imagery users to get there, but evidence and biological rationale behind it strongly suggests that they will. There's also some evidence in the psychology field, which I've only just really come across, and the fact that it takes 63 days to form and embed new habits. It's an area I'm really quite interested in, and hopefully maybe it will bring about a bit of a discussion later. It takes courage. The complexity of pain means that contributors and triggers can only be confronted with courage. And I think when we go through this process, we often find it brings out a lot of feelings, or maybe things that patients have tried to hide and put underneath. I'm not a psychologist, and actually very regularly will refer onto a psychologist to help support me and the patient going through this process. And it also takes commitment. This is not a quick fix. There is no magic pill, and I do not have a magic wand, as many people might think that we do. Instead, you will need to take this journey, or the patient will need to make this journey to recover and actually be content with it along the way. We try and get our patients to commit to coming to see us weekly to start with. Once they get the grasp of what it is that we're trying to get them to do and understand each stage, then we can negotiate basically coming less often, or maybe catching up more virtually, which seems to have worked quite nicely during these COVID times. The graded approach allows each stage to gradually increase the firing of the brain regions involved in the desired activity and aims to avoid setting off the pain neurotag in the brain. We're basically trying to get under what they call the pain radar. It can occur from one stage to the next, but it can also occur within each stage, altering the amounts and the activity. It requires really good education on pain and pacing, and the fact that the brain has this huge ability to be flexible and creative in performing the same tasks. And this is essentially what we're aiming to give back to the brain. Okay. So research has shown that people in pain often lose their ability to identify left or right of the images of the painful body part. And this ability appears to be important for the normal recovery of pain. fMRI studies have shown that pain experiences commonly activate the primary sensor and the motor cortex areas of the brain. However, the premotor areas of the brain are fired when patients are asked to do this left and right judgment. So, like I said, we're getting under the pain radar. At this stage, when I'm introducing this to my patients, I also try and get them to think about ways to relax or try to reduce stress. Because as I said earlier, the brain is taking in lots and lots of different information from around everything. And stress and mood and anxiety will all play into that. So I introduced to them a relaxation script, which has nothing to do with the body. One is about colours, one is around lightening your load. There's lots and lots of things on various different apps as well, called Headspace and Calm. Okay, so I think, as David Butler managed to explain, is that when you are in acute pain, you tend to be more aware of your hand. You're wanting to protect it. And therefore, when we show them an image, and let's say it's your left foot that is injured, if you show them an image of a left and a right, and they see the image of the left, they will automatically assume and think that it is the left, which is correct. And therefore, they will pretty accurately still manage to identify lefts and rights correctly. But with chronic pain sufferers, they get this smudging effect in their brain. They also have this thing of, actually, if it hurts, I don't want to use it. If I don't want to use it, I don't want to even look at it, because that just really annoys me and reminds me of the thing that doesn't work. I don't even want to think about it, because thoughts are nerve impulses too, and that also has a tendency to fire off pain in the brain. So when you then show them an image of a left and a right, let's stick with the left foot, actually, and you show them an image of a left foot, their automatic thought is going to be it's a right, because they don't even want to think about left. And if they then suddenly do realize that it is a left, well, actually, it's taken them longer to process that, because they've had to correct their original viewpoint of it being a right and changing it to a left. So the NOI app or their flashcards are really good tools, and you can use this for an assessment tool to work out what their accuracy and their speed is like. And then essentially after that, you can then use them as a training tool. I forgot to say at the beginning, I am not affiliated with NOI, Neuro Orthopaedic Institute. I earn nothing from any of these tools and things that they have. And you don't have to use them. They very much turn around and say you can make your own images, you can use magazines, you can use whatever it is that you want to use. So you don't have to. But the app does only cost £5, so I don't think it's particularly expensive. Okay, so before I tell you what normal is, let's see how normal you guys are. So this is where you need your piece of paper with your numbers written down the side. I'm going to stop sharing and reshare another bunch of images. And the slideshow will be of 27 images of different body parts. Each slide will show for 3 seconds, except for slide 17, which will show for 15 seconds, because there are 5 body parts on there that you need to identify. The important thing is to try not to think, just put down what you see first. And you need the numbers down the side, because if you miss one, then the slide will have a number on it at the bottom as well. So bear with me while I stop share and reshare. Sorry, I've lost my mouse. Sorry, let's try that again. I hate IT. Okay, got him. Okay, so are we all ready? Oh, I didn't press share screen, did I? Sorry. This is all going so well. Right, got it. Sorry about that. Okay, so are we ready? I'm going to click and it's going to start moving through. The first image starts on slide 2. So write down what you see, whether it's a left or a right. That's a little finger. Okay, we're getting a little harder now. Here's your 5 images. Let's see if you can identify each one. You've got that 15 seconds. Okay, 2 images there. That's a shoulder. Which way is he looking? Which way is he looking? And which way is she looking? That's a horse. Which way is it looking? And then some crazy dude who can do some funky movements. Okay. How did you find that? Okay, I need to share a different screen. Okay, so you may well have noticed that those are really quite tough. I wasn't going to make it easy for you guys. You guys are so-called normal. None of you guys are in pain. So I wanted to give you a little challenge. We're going to go through this again and see how many of them you got right. See if you notice a bit of a difference in terms of how the images are being displayed. All right. So I get that as a right hand, then a left hand, and a right, and a right, and another right, and a left, and a left, and a right, and a right, and a left, and another left, and another left. That's your right little finger. That's a left foot. That's another left foot. Okay, I get it, going from left through to right. Left, and the rest are all rights. That's a left hand. That's her right. They're actually both left. There's a mirror. That's a right shoulder. He's looking right. He's looking left. She's tilted her head to the left, but she's looking to the right. The horse is looking left. That's her right arm. That's a right leg. And then, bizarrely, a right leg and a left arm. Right. So, let's get back to PowerPoint. Okay. Yeah, there we go. Okay. So I guess at this point, I'm intrigued to know how people did. I'm hoping you found it easier on the second set of slides, and that is because all the pictures were put into their anatomically correct position. The brain finds it a whole lot harder to rotate and figure out which side we're talking about when the images are rotated. So that gives you a little bit of a hint in terms of progressions. Okay. So, what is normal? They did an online study which sampled 1,749 people looking at hand and neck, left and right discrimination, speed and accuracy. And normal, apparently, is if you get an accuracy of over 80%. How did you do? And that you did this with a speed of less than 2 seconds. So you see, I was ultra generous. I gave you an extra second per image. The app basically, which is a little picture on the right-hand side of that, has different images. Actually, there's a couple more other than that. They do a testing one. They then do a basic set of images. This is where the images are on a blank background, but they're all in the anatomically correct position. They then have vanilla, which is still on a blank-ish or plain background, but the images are rotated. Context, where the body part is doing things, and abstract, usually drawings, x-rays, pictures, you name it. So I would start with the basic images because of them being in the anatomically correct position, and it makes it easier. You basically progress onto different stages. When the patient is achieving an accuracy and response time which is equal lefts and rights, they need to be fairly stable, that they don't fade in and out depending on how stressed they are. They need to be consistent for about a week, and they need to be achieving an accuracy of around 90% or more with their response times less than 2 seconds. And this is where the app is so much better than just cards or pictures, because the app actually logs for you every time they play the games, the left and right discrimination, what the accuracy was and how fast they did it. The patients then can email the clinician those results, because there's a link through the app that you can put that to, which then means that the clinician can then monitor how the patients are doing. And if when they next attend and you have your next session, you can then maybe talk through why maybe they had a dip, what was happening with them on that day, try and get them to think back as to what they were doing, and help them to therefore recognize that maybe if they'd had a bit of a rotten day, why that might have affected their scores. So when they're getting these accuracy and speeds without flaring their pain, we can start to try and progress. And there are lots and lots of ways of trying to do this. So we can literally go from basic to vanilla to context to abstract. We can also think about actually how many images we display at once. So the app can display between 6 and 50 images. I tend to start around the 10 to 20. And then once I know that I'm not flaring them, then I quickly will move up the numbers. You can also change how long the images are being displayed for. The app will display them from, I think it's 2 seconds up to 30 seconds. For this part of the treatment, I would try and keep it quite short, and I certainly wouldn't have it more than the 5 seconds. We want this to be something that they think of automatically, and the longer the image is up there, you can't help yourself but trying to work out what position those images are actually in to try and figure out which side it is. So it needs to be an automatic, quick firing thing. If you are progressing from your vanilla through to your context and abstract, just be warned, there are some images within these, as you can see on the pictures, which are definitely more challenging for the patient. So they can be pictures of, as this one has it, after some surgery or during surgery in terms of that context one, or maybe images where the limb is being a little bit more challenged, like the rope being turned around it. These are there on purpose. They're there to try and stress the brain a little bit more, but you do just need to be aware that patients might find these more challenging and it might flare them. And if it does, you go back to your vanilla. Where are the games being performed? So I would always start with doing them in a really quiet, non-threatening, hopefully, no distractions going on type of room. Once they are achieving their scores, then you can start to introduce some distractions. So having something like the TV or the radio on in the background, having family around, I don't know, anything along those sort of things, or being out and about. So one of my patients, who I told him not to have any distractions going on in the background when he started doing it, came back to me sheepishly the next week saying, well, I kind of was trying to test your theories in terms of what would happen. So I put the TV on in the background, and he went, oh my goodness, it was so much harder to concentrate on what I was doing the left and right with having this distraction going on in the background. And it made me fizz more with his phantom. So honestly, it is amazing how simple distractions, when you are in a lot of chronic pain, can really affect how your brain is concentrating and working. Maybe you need to think about the time of day. Some patients might be better first thing in the morning than they are towards the end of the day when they are tired. But ultimately, they need to be able to work their way through such that they still maintain these scores even when they are tired. Need to think about your mood. If you're on a happy, chirpy day, you might fire through those absolutely no problem and get marvellous scores. It might be a little bit more difficult then to concentrate and keep those scores up high when you are maybe in a bit of a bad mood or grumpy. Different postures, I don't know, might change how you score too, in terms of sitting, lying or standing. And then, as I sort of have hopefully shown you when we did the little test together, that rotating images also makes it harder. Now, the app automatically does that when you go from your basic to your vanilla. But if you're using the cards or you're using your own images, then you would need to think about rotating those images too. There are different games that you can play other than just left and right. So there's tic-tac-toe, which is basically noughts and crosses. So you can pick to choose which side you're going to be, and then you try and make your line. You can play concentration. On the app, they start off with simple, which is basically just 6 images. You're trying to match equal pictures which are turned upside down, and then it works up to being more. With the cards, you could make it truly complex because there are a lot of cards. But there's basically equal and opposites, rights and lefts, but you have to try and match the two together. If you have cards, you can also play Snap with somebody else, and there is another game called Fish, but I would probably only recommend playing that game towards the end of the left and right treatment, because actually you're starting to slowly move into the imagery part because you're having to describe the card that you're looking for. And then how much should patients practice? So there was a study done out in Cape Town by I'm going to say it wrong, Limakatso et al., which suggested they did it every waking hour. But I think we need to be somewhat realistic. Definitely little and often. Do not do it all in one go. Another example of this was a patient who didn't listen to me, had a go on the app, and he basically worked through 50 images of vanilla, context, and abstract, and had flared himself up so badly by seeing so many images all in one go, without grading himself up to it, that he actually couldn't look at any more images after that. So please, little and often, not all in one go. Yeah, so I think maybe every waking hour is not necessarily feasible, but definitely throughout the day would be good. We are going to experience flares actually throughout the whole of the GMI process, and we need to think about what we're going to do about it when that happens. So it is not a set of progressions. I think it's probably one of the hardest things as a clinician. You like to go in steps, you like to work out, actually, how am I going to do this? And unfortunately, people are complex and their pains are complex, and therefore we need to work out what works for that person and actually negotiate with the patient what we need to do. Actually, if you've had a bit of a bad time about it, what can we do to make it a little bit easier to allow you then to eventually take those steps forwards again? So David Butler's advice is basically, if there's not doing any improvements, is, has it been being done enough? So it might need up to 2 hours a day, but like I said, not all in one go. Has it been being done for long enough? So the Cape Town study said 2 weeks. I would argue that's not enough. Some patients it might be, but I think the majority of our chronic pain patients will find that they need to do it for longer than that. It can take months of actually working through the different stages of the lefts and right discriminations. Like I said, there's no one answer for every patient. Has it been done in the different contexts and with the different tools? I explained those earlier, so you need to have a little go at all the different things. Is it being done properly? So in a quick but relaxed and automatic decision. Has it been embedded in favourable education context? This is where you really need to know and work out how to explain to patients about pain and about the process that they're doing. The Explain Pain book is brilliant. They also have a handbook which is for patients to use and works through all sorts of little like workshop type things throughout the book to help them to understand too. The Explain Pain book actually is written in such a way that I've had patients who've decided to purchase it, read it, and although they said, okay, it's a little bit heavy, it's actually very reader friendly. I don't like reading science books, and I was able to work my way through it quite well. So yes, they need to understand what it is that they're doing and why. The other thing is if they find looking at the painful body part too much, which I have had with patients before as well, you can actually start with a totally different body part, and that does seem to help and work as well. So if they have a painful phantom left leg, you could start off with looking at images of hands and then slowly work your way back down to looking at the legs again, and that does work too. And I think definitely also think that if they're having a flare-up and things aren't going as well as they should, you do need to look at thinking about what else is going on in their lives. Okay, so I don't know if this will work or not, but does anybody have any questions at this stage in terms of left and right discrimination?
So we actually got a couple of questions of our followers online, not just about left and right discrimination, but from the whole talk, if you want to answer them as well.
I haven't finished the whole talk. There's still a whole lot more to go, but at this point, let's see how we go.
Okay, the first question that we got is, With all your clinical experience, what were some of the more remarkable phantom limb positions you have observed? For example, unconventional locking of the limb.
Okay, I was going to talk about this a bit later on my case study, but I can do it now. He was a motorbike accident patient who his amputation level was a hemipelvectomy, and he'd been suffering with phantom pain for 8 years, seriously serious phantom pain, which was waking him up 2 or 3 times a night and would flare up literally every minute. And his leg position was essentially in the same position it was when he'd been on the motorbike when he had the crash. So basically in sort of full flexion at the hip and the knee. And it had been stuck like that for 8 years. And then through going through the whole of the graded motor imagery process, we managed to get it to move again. But like I said, that will be explained a little bit more. So that's probably the most extreme I've had. Other than one other patient I had who was single below-knee and transhumeral as well. And actually he had quite big telescoping of his arm where his hand, it was his left side, but his hand felt like it was right up into his stump. And again, through the following stages, which I'm going to talk through, we managed to get his hand to work its way back down again because I was trying to get a normal representation back into the brain. So I hope that answers that question.
Yes, thank you very much. And the next questions are more on GMI, and the first one of them is, which stage of GMI do you consider the hardest to work with, and why?
I'm coming to that stage next, so I'm going to hold off on that question.
Okay. Then maybe that's also something you're going to address in a minute, but the viewers were wondering how you measure the effectiveness of the GMI treatment.
Yeah, that I'll also cover later as well.
Okay, and then maybe one question that you can directly answer because it's concerning the app. A viewer was wondering, would it be the same pictures that are used in the app, or will there always be new ones, considering that you will learn to recognize the pictures?
Quite honestly, there is a huge bank of pictures in there. And yes, you'll see some pictures the same, but actually I haven't found a learning effect from it at all, in the sense that you see the same images over and over again. That would be probably the bad thing about the cards, is that you obviously only have a set number of cards, whereas with the app, I think because you have your basic, which really are on like black or white backgrounds, and then your vanilla, which are on neutral backgrounds, but it could still be things around the place. And then you've got context, and there are so many different things that are in context. An abstract is all your pictures and drawings, and they have like a foot imprint. Their imagination has been fantastic. I think it's a great app. It's made my life a whole lot easier in terms of giving it over as a training tool, and certainly the patients who have got it and used it have said how easy it is to use. And the fact that it's on their mobile phone, which means most people have their mobile phones with them all the time, so it's quick and easy. It doesn't take more than a minute to go through 50, well, okay, a minute and a half to go through 50 images, because they're only showing for like a couple of seconds. So it doesn't take long to do, whereas the cards or having your own pictures, you've got to carry a box around with you, you've got to pull it out, you've got to sort of flip them all out and about. So the app has made life easier, and I don't think that, I think there are enough images in there basically to not really get much of a learning effect.
Okay, perfect. Thank you very much. And now I'm curious to hear the second part of your workshop.
Okay, so once you have managed to work your way through all these different stages within the left and right discrimination, and they are maintaining their accuracy and their speed scores, then essentially your next part is the explicit motor imagery. So functional motor MRI scans have shown that when you imagine a movement, that your premotor and your primary motor areas fire, but not as many as when you move. So the aim of this stage is to regain the patient's ability to imagine movements in order to prepare the brain for actual movement. So explicit motor imagery is thinking about moving without actually moving. It can be quite hard work if you're in pain. In fact, quite frankly, I find it quite hard work not being in pain, and it's only through practice that I've gotten better at it. It's probably hard work if you're in pain because around 25% of the neurons in your brain are mirror neurons, which start firing when you're thinking of moving, or even if you're watching somebody move. Sports people use it hugely in terms of preparing themselves for good performances. I usually use the Johnny Wilkinson image from the Rugby World Cup, but that was a while ago now. So I am going to think of the Olympics more recently, and watching the athletics. Watch high jumpers before they go for their jump. They sit there, they stand at the end of their runway, their little runway, and they imagine and they think and they go through their run, and then you can sort of see them doing their like little perfect little jump. And it's been shown that basically the better you are at imagining what you're about to do, the better your performance is going to be. So we're basically exercising the brain for the rest of the body. At this stage, I consider using a relaxation script. So carrying on with this theme of trying to get patients to reduce down stress and anxiety. But the scripts now actually start to introduce a little bit of the body. So one of the ones I've got is Floating on the Cloud, where I describe briefly what it would feel like for your body to be lying on a cloud. It helps me to gauge the patient's reaction, to see how they are when I start describing their body. If it's not good, maybe then we're not quite ready for doing the imagery. We can give it a go, or they're not ready with the imagery to think about themselves yet. They might be ready with the imagery to think about somebody else, because that's not as challenging as thinking about themselves. As I go through the imagery, if they're okay with me introducing about themselves and thinking about their body, then I might trial a body scan script, and there are lots out there with yoga, etc., which goes into a lot more detail describing what it is that they are feeling as you work through different parts of the body. So that's a way of me gauging whether I'm also ready to move on to the next stage again. Okay, so like I said, this is the training of mirror neurons. These are cells which fire when we watch activities or imagine activities, because thoughts are nerve impulses too. You can use the cards, you can use your own pictures to basically describe what it is that you are seeing, or you can use the app, as this picture is showing, of somebody's foot in the sand. And what I would do is I'd use the context images. Like I said, you might need to be careful with some of the more challenging pictures. Slow it right down to 30 seconds, because now we actually want them to be thinking about what it is they are seeing. Yeah, we can still say, is that a left or a right? But for this one, I'd want them to describe to me what it is that that person's foot is feeling in the sand. And then if they're all right with that and it doesn't flare them, then I would probably get them to think about trying to describe what they might feel if it was their foot in the sand. This is the one that I find patients struggle with the most. Okay, so hopefully that answers the question earlier. I used to really struggle with it. I used to do sport, and I remember being sat, I used to row, and I remember being sat in a row of 8 people before doing a big competition, and the cox telling us what we were going to be experiencing and feeling as we went through. It was the 8th Head of the River race, and me sitting there going, what is she on about? This is a load of absolute nonsense. Okay, I've learned. That was a long time ago. I now know the difference, and I can absolutely advocate just how powerful this can be. If patients are really struggling with describing a picture or something like that, then what I have found helpful is to get them to describe something that they like to do. I say to do because if it's something that they can no longer do now that they're an amputee, it might upset them that they can't do it anymore, and therefore it might be quite distressing. So my motorbike patient, who I was briefly describing earlier, he really struggled with this concept until I turned around to him and said, okay, look, you're still racing your motorbike, fool that you are, but you are. And he was actually racing it going around the various racetracks. I said, okay, I want you to think about your favorite racetrack, which was Brands Hatch in the UK. And I said to him, okay, I want you to imagine yourself on your motorbike. I want you to describe to me out loud what it is that you are feeling when you go round the racetrack. But I want you to really focus on what it is you are feeling on the motorbike, on your legs. So the vibration of the engine, the warmth of the engine, the wind pushing against the leathers on his legs, maybe the feeling as he goes down around the corners. And he really got into it. It was quite interesting to listen to. And he came away at the end of it when he went past the finish line. And he went, wow, he said, I really could feel that. I really pictured myself going around every single corner straight, the trees, the everything. And I could really feel the engine. I could really feel the motorbike underneath me, and that was really quite powerful. So it does work, but it does need to take a little bit of practice. So some guidelines for imagery. Watching is less brain effort than imagining. So watching somebody else is less effort than you imagining what you're doing. Maybe try with statics first, static positions first, and then go on to movement. Consider or watch what it might feel like to have a body part in a certain position, and then consider or watch what it might feel like to have a body part doing a certain movement. Because like I've said, imagining another person is less demanding than imagining yourself. And then eventually progress on to more feared movements or environments. So that might be where actually some of the context images might be helpful, like that one with the rope wrapped around the foot, that maybe they could describe what that might feel like. I would also say that just because you've moved on to the next stage of GMI doesn't mean that you should stop doing the left and right discriminations. I have found that, so this patient from the motorbike, he was one of my first, and I learned a huge amount from him. We hadn't originally carried on using the app. And he said, I'm really struggling with the imagery and I don't really feel like I don't know what to do. I said, well, then carry on doing the app, carry on doing that. And I think it was just a really, because it's so simple and easy to do, it was just something that he felt he could carry on doing while he was maybe struggling to come to terms with how to do the imagery. And he was finding it quite helpful. So, okay, so here is another little practical session. And this is where I wish I was in Gothenburg with you guys, because I could get a bit more of an audience participation. But I don't know, maybe we can try and make this work. So, can anybody describe, this is what I say to my patients, can you describe what you would feel walking barefoot on a summer's morning on some freshly cut grass and there is dew on the ground? If you don't like that one, then maybe can you describe what it feels like walking barefoot on a sandy beach as you start from the dunes and you work your way down towards the water? What do you feel? What can you see? What can you smell? How does it make you feel? So is anybody willing to maybe shout out some of their feelings that they are imagining? Maybe not. It's not that easy. Okay. So I would suggest that maybe walking on that freshly cut grass, it's a bit wet because there's dew on it. Probably feeling a little bit squidgy too. The grass has only just been cut. Maybe it's a little bit prickly underfoot. And you can feel the grass in between your toes tickling. Maybe you can smell the freshly cut grass. As far as the beach one is concerned, what I'm actually going to do is read through a little bit of a relaxation script which describes the beach. I think I've got just enough time to whip through one of these. So if you'd like to all make yourselves comfortable, try not to fall asleep. I know it's the morning. Well, it's the morning for some of us anyway. But have a go at closing your eyes and relaxing your body. Breathe slowly and gently. And take your time and focus on smooth, even breaths. Now imagine that you are on a beach. It's a small, sheltered cove, and you have the place to yourself. It's a beautiful day, and it's perfect for walking. It's not too hot, and it's not too cold. And the sky is a remarkable shade of blue, and there is not a cloud in the sky. The water sparkles in the sunlight, and the breeze that comes off the water smells salty and fresh. Look out over the water and inhale the clean air. While you breathe in, imagine that the air is filling you with energy. And as you breathe out, feel your pain and anxiety go out with your breath and fly away over the water. Under your feet, the soft sand is lovely and warm. Imagine curling your toes and feel the crunch of the grains of sand. And the warmth from the sand travels up through your feet, making your whole body feel warm, relaxed, and calm. Ahead of you is a large, flat rock jutting out into the water, which is perfect for sitting on. Climb onto it. The surface is slightly rough, but it's warm and comfortable. And from your spot, you can see out into the water, and you can dangle your legs over the edge. A wave comes towards you and splashes your feet. The water is cool and refreshing. Enjoy the small fish that you can see swimming around in the pools next to you. And notice how your body feels heavy and relaxed. You're calm and not feeling any pain. Then, when you're ready, stand up and walk further along the beach. Enjoy all of the sights, sounds, and smells that you experience along the way. The gentle lapping of the waves on the sand, the warmth of the sun on your shoulders, the crunch of the sand under your feet, smell of clean, fresh sea breeze, and think about how relaxed and comfortable they make you feel. Now the time has come to leave the beach. But remember that you can bring these feelings and sensations along with you. And know that when you need to, you can easily return to your special beach cove. So open your eyes, continue to breathe smoothly in and out, and take time to notice how your body feels. Hopefully relaxed, calm, and peaceful. Whew. Okay, I wish you were on that beach. We use a lot of relaxation imagery with our practice, and this was just one way of maybe helping you to work out what it is that you should feel. And I think it has certainly helped with our patients to get to become in tune with their sensations and their imagination. So, any questions on the imagery? No? Okay.
Yes, actually we do. So the audience wants to know, with motor imagery, do you ask the patient to move his/her stump or the phantom limb?
No, absolutely not. That's the next stage. So this is definitely purely about imagery. So this is purely thinking about what it would feel like if they were to move, but without actually moving. So absolutely pure imagery.
And the next question is also, do you use scripts that include prostheses or residual limbs?
I haven't used any scripts with prosthetics, partly because I haven't found any and I haven't made any of them up. And I don't stop at the stump or the residual limb. I literally get them to imagine the whole of their leg or the whole of their arm, because I want them to have a normal feeling of a whole body.
Perfect, thank you very much.
All right, so when they can do all of this imagery and have it fairly well embedded and are able to bring it on quite easily, they're not flaring up their pain doing it, then we start to be ready for the next stage. It's like I said earlier, when I think that we're getting towards the next stage, I will introduce the body scan relaxation, which literally goes through the whole body just to gauge their reaction. Because the next stage is mirror therapy. I was going to try and demonstrate this, but I could not figure camera angles. And then the guys yesterday very handily demonstrated it quite well. So I thought, fantastic, I don't need to. And actually, probably out of everything, mirror therapy is probably the best known. So, as we know, mirrors have been used since the mid-1990s when Ramachandran introduced mirrors to help treat phantom limb pain by regaining motor control of the missing limb. It provides visual feedback of a healthy limb that looks well, moves well, and is fully endorsed by the brain. It provides a smaller jump from explicit motor imagery to functional exposure. And we're essentially using the mirror to present a reverse image of the limb to the brain and therefore are tricking the brain. So this is moving from imagined to actual movements of the affected limb in different contexts. I find that the greatest pain relief felt is by those patients who are able to imagine moving their limb more. And therefore, before each session that I do with mirror therapy, I always do the body scan first to help them to get back in tune with the patient's body and to enhance those sensations more. So, just a few mirror box practicalities. Make sure that the mirror is not distorted. It's very powerful, and if it's distorted and shows your limb looking a little bit funky, that's not so good. The mirror box is extremely powerful. If any of you have ever had a little play in a mirror box and tried to do opposites with your hands to what you're seeing in the mirror, it messes with your head. So it can evoke a huge amount of emotion. My motorbike patient, again, he thought he was extremely well adjusted to the fact that he was an amputee. He was active, he was back at work, he thought he was at peace with the fact that he was an amputee. I put him in front of the mirror. He definitely went a little bit quiet throughout the session. I thought, oops, I pushed it a bit too quick. He came back to me the following week and he said, don't worry. He said, I am okay. He said, but that really surprised me. I thought I was okay. And seeing my leg again really brought back a huge amount of emotion. And yeah, it was just very powerful to him. But he'd worked through that and we were able to move forward. But I think I have had, before I knew about GMI, my predecessor was using mirrors and I'd seen it myself before. You just cannot predict who is going to have an okay response to it and who is not. And I think this is where I like GMI more, because you have all this preparation work beforehand, such that hopefully by the time you get through to the mirror stage, they are better prepared to see and feel their leg again, or their arm again, whichever body part. I keep going on about legs because, quite frankly, the majority of our patients are lower limb amputees. So that's why I keep going on about legs. You need to remove any jewelry or anything that might identify which side it is. And if it is legs, then you probably want to remove their socks and shoes. But again, be warned, you know, the majority of my patients are amputees due to peripheral vascular disease or diabetes, and an increasing number of septicemia survivors. And they can have some limbs that aren't maybe looking quite so healthy. So that might then be something that you want to keep covered up and keep their socks and shoes on, for example. I start with just looking at their leg. Something else that, other patients have told me. Phantom pain patients have told me that essentially it feels more real and more vivid to them if their remaining limb is not touching the surface, so that their foot is not touching the floor or their hand is not touching the table. Their phantom limb is not getting any sensory feedback. So to make it feel more equal, if their remaining foot or hand is not touching something and not getting any sensory feedback too, then they find that more real. But you try and do that with your legs when you don't have another leg to balance with, to keep both legs up off the floor. It's not easy. It's really challenging on the core. So you need to be really careful and think about your setup to enable that to happen. And I don't have an easy answer to that one, other than a mirror big enough that maybe they can lean on to help with their core. You need to make sure that the phantom side is covered. I've had patients doing it with and without their prosthesis on the other side. And so you need to make sure that that side is covered to stop the distraction of what they're seeing and make sure that what they're focusing on is literally what they're seeing in the mirror. Like I said, I start by just looking at their mirrored limb first and get them to imagine and look and describe what it is that they are feeling, which again is not necessarily the easiest thing to do. You don't really think about what your leg feels like just looking at it. So I often have to prompt them or help them along. So your descriptive skills as a therapist need to be pretty hot. We then start doing exercises, and to answer one of the questions earlier is that I've definitely found that phantom limb pain patients find that they need to exercise with both their phantom and their remaining leg in the mirror at the same time to make it feel more realistic. It depends on the patient. I either get them to try and match what their phantom is doing, even if it's only a small movement. But if you look at actually what the NOI group and the GMI people talk about in terms of doing movements, they actually encourage you to work through the full range, even if your limb behind the mirror can't do the full range, because you're trying to encourage the brain to see normal movement again. I hope that kind of makes sense. With my motorbike patient, his leg was pretty much stuck in around 120-degree knee flexion when we first started doing this. And by him basically practicing and working with his remaining leg and working through the full range and trying to get his phantom to gently, not pushing it, but to try and gently copy that, essentially then he was able to get more movement. Actually, any movement was good. We managed to get to as far as minus 35 degrees extension, which I think is quite a big improvement. So anyway, yeah, what else? Bilateral patients. Honestly, I really don't know what to do with them when it comes to mirrors. In fact, I have had a patient recently who was a bilateral, and we actually decided not to do the mirror because he'd found that the app and the imagery had been powerful enough for him and had helped to reduce his pain sufficiently. So I didn't need to, I don't know, see what anybody else thinks on that one. All right, so that is that bit. Maybe I'll take all the rest of the questions at the end because I'm just twigging what the time is and I've got a bit more still to go. So as mentioned earlier, and as we know, that pain is not just the biomedical model of pain, and that tissue damage, in that pain does not equal to the amount of tissue that has been damaged. And or with the case of phantom limbs, well, there ain't no tissue there to be damaged. I think I heard her Flor say yesterday that her students really like treating phantom pain patients because, like me, I can categorically tell them that their limb is not in danger and it is not damaged anymore. Pain also heavily relies on context, and therefore we need to treat the patient holistically and individually. And we need to look at other factors that are affecting the patient's experience of pain. And this is where the Protectometer comes in, which is what you can see on your screen. So this Protectometer is an indicator of the overall level of danger in me or safeties in me, so DIMS and SIMS. And this indicator will move up or down in response to the evidence of danger or safety in your life. So DIMS are on one side, and they are all the things in your life that tell your brain that your system is in danger and is in need of protection. Everything in your life. Messages from your tissues, messages from your friends, family, partner, who maybe are thinking, how can you possibly be feeling pain on something that's no longer there? You're crazy, it's all in your head. Out-of-date healthcare professionals, who maybe are saying something similar and not quite believing them when they're saying how much pain they are in their phantoms. Things that you say, things that you do, things that you hear. SIMS, on the other hand, are evidence to the brain of safeties in me. So all the good things in your life, the understanding of pain, the understanding of why I can still feel my phantom, the understanding from friends and family that you are not crazy and that your pain is real, that your healthcare professional understands and gives you the tools I've just been talking about, to help. And that can believe, and that you believe, and everybody else believes that your pain can get better. So patients in pain tend to have more DIMS than SIMS. And the more chronic the pain is, the more difficulty they have in finding and identifying SIMS. So part of the treatment process is in exploring patients' DIMS and maybe dispelling some myths or exploring if we can get the patients to change their DIMS into SIMS and to get patients to recognize the SIMS in their life. Okay. You will have pain when your brain concludes that there is more credible evidence of danger and DIMS than there is credible evidence of safety or SIMS. And that is the true vice versa. So you will not have pain when your brain concludes there's more credible evidence of safety in me than there is of danger in me. Like I said, I am not a psychologist, and I will often get my patients to see our psychologist alongside the GMI treatment. I had one patient who'd been suffering with phantom limb pain for 40 years. He'd lost his limb in his 20s, and he had never truly come to terms with the loss of his limb. He hid it from everybody. He wore his prosthetic all day. He'd only ever told his close family. He hadn't told his work colleagues, and it was affecting everything in his life because he was then having this really awful pain. So while I was working on his pain side of things, our psychologist was then working with him on coming to terms and the acceptance of his amputation and strategies to help him to manage that and speak to his family and friends. And I remember him coming in to me once and said, "I did it, Kate." He said, "I did it." He said, I went to the pub with my friends and I told them I was an amputee. And he said it felt like a huge weight had been lifted off my shoulders. I said, "All right, and what was their reaction?" He said, "Yeah, they all knew." And it was just this relief, I think, and just realization that it really didn't matter. It didn't matter to his friends and actually to his work colleagues when he told them. It didn't matter to them that he was an amputee. It was something that he had put onto himself. Okay, so let's see if you guys are able to come up with some thoughts which match onto these topics, which are part of Protectometer. So you have things that you hear, see, smell, taste, or touch. Things that you do, things that you say, things that you believe or think, places that you go, people in your life, and things happening in your body. I'm just going to give you 30 seconds to a minute to maybe try and scribble down some thoughts and see if you are able, in your own, or if you want to think about a patient that you've seen, think about anything that may go into some of those topics. Don't worry about thinking whether it should be a dim or a sim. We can maybe explore some of those later. All right, have a little go. Okay. Now, if you're anything like my patients, you might have struggled a bit when you're being put on the spot like that. So like I said, I definitely find my patients struggle when I say, "Come on, think about some things." So what I tend to do is that when I'm chatting with them or going through an assessment with them, or both actually, as they're just chatting with me and talking with me, I'll tend to scribble down some things that I pick up and put them onto some post-it notes. And then essentially I'll then go through them with the patient, and then between us, we'll try and work out which of those 7 topics, what I've written down on the post-it notes from what they've told me, where they go. So just to give you a little example. So up on your screen now, hopefully you can see something which is from the Explain Pain Handbook, Protectometer, and these are basically some examples from there. So these are from general pain. But if I maybe give you some examples from one of my patients. So in terms of the first topic of things you hear, see, taste, and touch, he'd identified that he loved the sound and feel of my motorbike. He then also had, "I love great food, but I hate soggy mushrooms. I love good music, but I can't stand jazz." All right, so those are just a couple of things. The second one, which is basically things that you do. So he said, "I feel out of control sometimes. When the pain is really bad, I get uncontrolled muscle spasms. That's embarrassing. And it then impacts on me doing things, and I hide away." So that is clearly a dim. All right. "I can't do what I used to do, and this frustrates me." That's also a dim. But I have to say, in terms of thinking about how I might go about changing that, well, I think we all find that as we get a little older, we can't do things the way that we used to do. But also, in terms of our amputees, just because they're an amputee now might mean that they can't do things in the same way, but it doesn't mean to say that they can't still do it in a different way. And this is where we might then have to get them to think around, help them to problem solve, help maybe give them some tips and some websites to go and have a look on, or whatever it is, to try and help them work out that actually they can still do this thing that they thought they couldn't do, but they just might have to do it in a different way. And then hopefully move that from a DIM through to a SIM. In terms of the uncontrolled muscle spasms, well, hopefully as they're going through the GMI process, which is what happened with this patient, is that his muscle spasms absolutely reduced right down, such that he didn't have that anymore. And that when they did still come, that he had then the tools to help calm himself and able to disperse those spasms so that it wasn't so embarrassing for him. Number 3, things that you say. I don't say enough when I need help, or saying everything is all right when it isn't. I think we can all be guilty of this sometimes, is that we don't always ask for help when we need it. And I think actually there's no harm in asking for help, and it is getting patients to understand and realise that. We all have our strengths and weaknesses, and I think we just need to play to our strengths and ask for help when we recognise maybe something which we struggle with. As another quad amputee turned around to me and said, you need to work out which battles that you need to fight for and save your energy by asking for help for those battles which are just too hard. Number 4, things you believe. So he thought that you could only manage phantom pain and that you couldn't treat it, and that the only way to help manage it was with medication. Well, hopefully through all the education processes that we've been talking about and going through the GMI, they learn and realise that actually, yes, it can be treated. Places you go. Going to hospital. Well, they could be a DIM or a SIM, depending on your experience of going there. So hopefully we can make it more of a SIM by it being a positive experience by coming in to see us as clinicians. People in your life. His sister, he couldn't stand, so she was definitely in the DIM, but the rest of his family and friends were definitely SIM. And then things happening in your body. So getting old, he really didn't like, but he did love his new glasses because he could see again, and he loved his new microprocessor knee because he was able to walk better. So hopefully that's given you a few ideas. I'm going to whack through. I really want to put across the importance of language and other considerations. You can set patients' expectations without even realising it. If your first question to patients is, do you have phantom limb pain? Then that sets up the expectation that all phantoms are painful. Surely it would be better to ask, can you feel your phantom? And if they turn around and say yes, then you can turn around and say, great, fantastic. They look at you as if you're a bit mad, but that's okay. You can explain to them why. And then ask, is your phantom ever painful? And if they say yes to that, then you go, okay, that's not so great. But these are some of the things that we can then try and do to help to relieve that pain so that you can just feel it rather than it being painful. We want to encourage our patients to regain a happy, healthy, functioning representation of their phantom limb. And like I said, I personally think it's easier to convince our phantom pain patients that because their limbs are no longer in danger. And then have a little think about where you are in relation to the phantom limb. So if you are sitting in front of a patient who is a, I don't know, above knee amputee, and you are asking them to have a go at trying to extend their knee, well, if you're sitting in the way, they're going to kick you with their phantom, and that's not normal. Or if they're lying on the bed on their backs and you're wanting them to flex their leg, well, your leg shouldn't be going down through the mattress. So please have a little think about where you are or where they are in relation to where their phantom is and what it should be doing. And then this is one of my little bugbears, never, ever say you'll be back in a minute. I don't think anybody is ever back in a minute, and therefore patients get really frustrated and stressy and go, well, where are they? Where's my meds? They said they'd be back in a minute. The prosthetist said they'd be back in a minute with my leg, and I'm sitting here waiting. Where are they? It's not great. Help with their expectations, help reduce down that stress and anxiety and frustration by setting realistic expectations throughout. It's okay to be a little bit sore, but we need to be safe. And then I hope that the no pain, no gain translates into different languages, but I think it's quite a powerful thing. No pain, no gain spelled N-O compared to no pain, no gain spelled K-N-O-W. Oh, I'm running out of time. Okay, just really, really quickly, I pulled a few results from patients that I remembered that I could see. Like I said, I'm a clinician, not a scientist, and hopefully this graph on the top right, that one, actually had some really good results. I've been using the McGill pain questionnaire, and this is the pain descriptor. I know not everybody likes the McGill pain questionnaire, but I just found it quite useful and easy to use, and got some really nice results coming down. The case study I actually just very briefly described earlier with my motorbike patient, and you can see the change in his left and right discrimination scores down there in the left-hand corner. And then his McGill pain scores dropped from 44 out of 78 down to 6. And where he was being woken 2 to 3 times a night with his pain, he was no longer getting woken up by pain. And his flares, which he was still getting 2 years later after treatment had finished, were only every 6 weeks. And actually, I spoke to him last year at the beginning of COVID, and he said his pain now only comes when he is about to get ill, which I think is very interesting in terms of immune cells also being part of the pain experience. A little bit of qualitative feedback from other patients. I still use the Protectometer to remind myself and work out how to change my thoughts and feelings. I use the Calm Headspace app. I listen to your recording relaxation sessions, which help me to sleep better. I can feel my foot where it should be when I'm walking. I have continued with the mental exercises and processes. It's now almost automatic, and I can call on them as and when required. This motorbike patient had actually backed off his drugs hugely, which he said has allowed him to be more active and engaged throughout the day because he wasn't quite so zonked out. My favourite quote of all of them, I'm just looking through them, is, "I'm now in control of my phantom rather than my phantom having control over me." And that was just so good to hear when this patient said that. And that is certainly my goal when I'm treating patients with GMI. So just again, quickly, how I use GMI. With primary patients, my gut feeling is they haven't lost their ability to lose left and right. They are not chronic pain patients. They are acute. They've just lost their limb. I also don't, quite frankly, have time to go through the whole GMI process with every single patient that comes through our doors which experience phantom pain, and especially at the acute stage. So essentially, we do an enormous amount of education. We try and get them to normalise their feeling of their phantom as quickly as possible, even day one, to get them to feel and move their phantom in a normal way, to give them this control. Do lots and lots of relaxation work and help with managing their expectations. I think we need to remember that our phantom pain patients are going through, our primary patients are going through an enormous amount. They've just lost their limb. They're in hospital. They've lost control. They've lost their independence. All these things that are going on. What's the physio going to do to me today? What's my prosthetic going to feel like? With these anxieties and stresses, which is basically just going to up the system and make their pain worse regardless. And then our chronic pain patients, those are the ones that I'll go through the GMI process. They're usually referred from the doctor. It is incredibly important that we assess them first to make sure it is something that we can treat. I have had patients referred to me for phantom pain only to discover that actually it was a failed myodesis that was causing the patient the pain, not phantoms, and or that the socket wasn't fitting well. Got the socket changed. That made their phantom pain a whole lot better. So I hope that's given just a brief overview. Couple of reflections. Progress is not always smooth. Are they pushing the boundaries? I find you shouldn't try to reduce the medication until the GMI process has finished and that their phantom limb pain is stable, and then basically work with the doctors to work on a graded reduction of the meds. Don't be afraid to take a step back. Sometimes taking a step back allows us to take several steps forward. It is phenomenally important for patients to have support from home and to help them to engage in education and GMI process. I invite patients, partners or family to come in and listen to the education so that they can understand. Do the homework, don't stop the previous stage. I've said all of those. Think about how long. And one more. Use the relaxation scripts. Really be careful when progressing onto the mirror therapy. I think the principles of GMI are incredibly useful for treating acute phantom pain patients. Patients are individual, people are complex. It's not simple, and you've got to work it out with the patient. I think definitely acknowledge outside influences, and I have found COVID to have really increased people's stresses and anxieties, which has not made life particularly easy. And then just to remind everybody, pain is really quite essential for survival. We do need to be able to experience pain, but just appropriately. And then that's it, basically. Pain is clearly in your body, or in our patient cases in their phantoms, but 100% of the time, without exception, it is produced in your brain. No brain, no pain. Sorry, that went over.
Thank you so much, Kate. In the interest of time, I think, if you agree, I would forward you a couple of the questions, because we got many interesting questions, and it would be nice if you could answer some of them so I could send then the answers to our viewers online.
Okay, I'll have a go doing that.
All right, perfect.
Thank you very much.
Thank you so much for this amazing workshop. And with this, we conclude our first workshop of this morning. We take about 20 minutes break. We're back on the hour at 11 o'clock with our third workshop of our conference on phantom motor execution. Thank you again, Kate.
Thank you.